So speaking of EGFR and PD-L1, Lonnie, again, the critical role you play to make sure we get the information that we need. You are sort of the start of all of this. Can you talk a little bit about, again, not just biopsy techniques, but the tissue journey and how you ensure enough tissue when you're there and where it gets sent off to, and then we'll talk to Sam about what he does with it when he gets it.
Yeah, sure, man. So I think this is a great discussion and opportunity for bringing in multiple different specialties. So, for example, this case from a minimally invasive approach, I completely agree with Mickey about endobronchial ultrasound, but the adrenal gland is easily accessible with esophageal ultrasound. So it seems like a great opportunity for a combined procedural approach of EUS with gastroenterology and endobronchial ultrasound, and then you can really make a confirmatory diagnosis of metastatic disease. You can appropriately, as Mickey addressed, stage the mediastinum, and then work towards tissue acquisition for ancillary testing.
Talk a little bit about Rose and having an on-site pathologist in the room and where it goes from there.
Yeah, so ROSE, or Rapid Onset Evaluation, has really become an integral part of our procedure interface. And not so much from an evidence base of improving or increasing diagnostic yield, but really reducing complications and improving adequate tissue acquisition. So having the cytotechnologist or cytopathologist or pathologist in the room providing feedback as we move from procedure to procedure, again, allows us to confirm a diagnosis, but also give us a stop point of when to collect, when to stop, and also what's becoming, I think, a lot more meaningful in the literature is what medium or what preparation techniques are to be utilized to ensure that Sam has the appropriate information that he needs to, the appropriate tissue and amount of tissue so that he can go on and do testing.
So Sam, talk to us a little bit about biomarker testing. This is, the first case was a squamous cell. Maybe we do PD-L1. Yes, we do it reflexively. But this is an adenocarcinoma. This is a never smoker. There's a high likelihood of finding a genetic aberration. Walk us through current guidelines for molecular testing for your garden variety stage 4 adenocarcinoma patient.
Yeah, so this is a stage 4, as you mentioned, and in advanced stage 4 disease, biomarker testing it should be done in all these patients. I will say often in the pathology lab, we don't know what the stage is when the specimen comes to us, and would encourage optimal communication between the team members and when that specimen comes down to pathology. If we know it's stage 4, if reflexive testing is not done, it helps us do the testing. But certainly in a stage 4 patient, it should be done. You've got really 3 buckets, I guess, today. You have your oncogenic driver mutations, and these are greater than 99% of the time are going to be mutually exclusive. This is going to include EGFR as well as KRAS, BRAF, HER2 or ERBB2, even NTRK. These are all oncogenic driver mutations are mutually exclusive. You then also have your immuno-oncology markers. So you've got PD-L1, that being the immunohistochemistry, and then you also have your MSI and some other markers. Really, ideally, I think they all should be done in an advanced patient like this. Next generation sequencing can be used and can get many of these results, although not all of them. And it really requires the pathologist to be actively involved from the beginning. So a pathologist being involved in the evaluation of the biopsy is going to make sure we've got adequate tissue. If you don't have adequate tissue, which is does happen even with Rose, sometimes the procedure has to be stopped. The discussion about what can we get done, sometimes you have to triage it. The guidelines would say in a patient like this, they were updated in 2018, the CAP is like AMP guidelines. At a minimum, EGFR, ALK, ROS1 should be done. There's expert consensus in those guidelines that I think has since moved on to, this should be standard of care, for BRAF, and now NTRK probably should be part of it. Now to get NTRK, it's a very low frequency abnormality, and so that almost pushes you in many of these patients into next generation sequencing, but that requires more tissue than you can get with some of the hotspot tests. So it does require a multidisciplinary discussion, and the pathologist knowledgeable about what testing what their testing requirements are and what they think they can realistically get off the sample they have, and potentially a discussion about going back, maybe even though you can use an ultrasound guided technique to get to the adrenal, maybe a laparoscopic procedure to get a generous amount of tissue. One last comment, primary versus metastatic site. For most of these abnormalities, you're going to get the same information whether you test one or the other. Especially with the oncogenic driver mutations, they're the same. There's not a lot of data out there about heterogeneity for some of the other markers. The metastatic site from a biologic perspective is generally going to be your most advanced with mutation status. So in some ways it would be preferred, but that's without solid evidence.
Lonnie, I want to go back to you real quick. In terms of the tissue acquisition and using EBUS, there are people out there who say, well, EBUS can't get enough tissue for molecular testing, and there's some data on 4-pass FNAs. You can use a core with an EBUS, I understand, at times, or a larger needle. Talk to us about the success of getting enough tissue with your tools.
Sure. Yeah, I think it's, as Sam mentioned, I think the communication between all parties is pretty essential, starting with understanding what the procedure is for, right? So if we already have a diagnosis, we go in up front with communication with our pathology colleagues that I'm going to do basically one smear, confirm that I have tumor, and then everything else is going in a separate block to be tested at a later date. So tissue preservation, I think, is pretty critical. And to that end, we think there's a lot of promise in on-site preparation. So there's a lot of controversy on needle size, on which medium to place different samples in. There's guidelines that are actively being done right now in the field. But whatever the technique is, it should be catered to the institution and what pathology is used to doing and comfortable doing, and then optimizing that to ensure that you have enough tissue for testing.